Dr. Hassan Razvi, who invited me to your meeting. And of course, Hussein was one of our fellows in London. He was a terrific fellow, was very productive, and it's been just a real joy to see his career flourish here. And thank you again, Hussein, for inviting me. So greetings from London, Ontario, Canada. For those of you who don't know Canada, we're just about 2 hours west of Toronto in southwestern Ontario. When I left a couple of days ago, that's sort of what it looked there, our campus with the fall colors. But when I go back in a few days, it won't look like the bottom panel with snow on the ground. It's time of year that can happen. So these are my disclosures, and none of these are relevant to today's presentation. So what I'd like to cover in the next 20 minutes or so is a comparison of the HOMI-YAG and the thulium fiber lasers in particular. I want to review some of the preclinical and the clinical data, specifically with respect to lithotripsy and some of the soft tissue applications, and try to answer the question: is the thulium fiber laser really all that it's been promoted to be, or are we really looking at more marketing hype than truth? And we'll try and cover some of the key aspects of that discussion. So the HOMI-YAG laser, don't need to say too much about this. You're all very familiar. I mean, it's really the workhorse and clearly the gold standard intracorporeal lithotripsy device. It has been so for 20 plus years. Why is it so considered that? Because, well, it works so well, right? It breaks up all stones of all compositions. It's a fairly safe device to use. And there are excellent soft tissue applications, particularly for prostate and colon procedures, now widely embraced and practiced throughout the world. But I think we also realize, as we've used it for this 20 plus years, is that there are some limitations, and lower power capabilities, particularly with the early devices, may have limited some of its benefits. Initially, the machines that we had, really, we could only alter two things: the energy and the pulse frequency. But now, with some of the new modifications, perhaps there have been some advantages, and we'll talk a bit about those. But I think one of the main limitations I think many of us recognize is when we're dealing with the flexible ureteroscopes and lower pole stones, some of the fiber issues with HOMI-YAG do limit its ability to get to stones. And this X-ray here is showing the retrograde, showing really a very dependent lower pole, where we're putting that flexible scope through a lot of angulation and deflection. And sometimes the HOMI fibers will not be passed into that lower pole to deal with the stones effectively. So some limitations, but I guess the question is, are those limitations significant enough that we need another laser? And if you look historically over lasers that have been available to us in urology, there's a number of them listed here. Some of them maybe you've heard about, or maybe even you've used, but where are they now? Of course, they're gone because there were some problems with all of these three devices. But we do have other lasers in urology which are still being widely used and are very effective, particularly for various soft tissue applications listed here. There's the new HOMI-YAG, perhaps a bit historic, but there's some parts of the world that still use it for soft tissue. Ring light, of course, excellent tool for prostate, CO2, used for a variety of cutaneous applications. Thulium-YAG, thulium fiber laser, different types of lasers also have some applications. And again, just to make the point, though, these are two very different lasers. The wavelengths are different and the applications are different. The thulium-YAG laser predominantly has been utilized for soft tissue work. There are a number of trials that have shown that it's a very similar tool in terms of HOMI-YAG enucleation of the prostate. It can work very well. The thulium-YAG laser historically has not been utilized, though, for lithotripsy applications, although I understand there is some work ongoing, particularly in France. Dr. Traxler is working on perhaps modifying the thulium-YAG laser for lithotripsy, but as yet, we really haven't seen much clinical work with respect to that. But the thulium fiber laser, which is what we're going to talk mostly about here this afternoon, certainly is a very effective tool for lithotripsy, and actually has been around for a while, certainly in the literature, although its clinical application is, of course, relatively new. So a device that was initially described in 2005, like a diode laser, so a different type of technology than we're used to see with the HOMI-YAG. And why that's important is it allows miniaturization of the laser. It allows a much more user-friendly device in terms of setup, and it may be particularly beneficial with certain applications, which we'll talk about in a moment. In this initial work by Dr. Freed, he commented on a couple of things that are unique to this laser, particularly this wavelength, which is different from the HOMIUM, and that it allows for some very unique properties. And those include the ability to ablate tissue or ablate a stone much quicker than we would see with homing laser, 2 to 4 times faster than his very initial in vitro work. And also notice there's less retropulsion, and I think we've all experienced that, dealing with the stone and a hydronephrotic ureter with homing laser, we're often chasing that stone up the ureter, and sometimes that's a bit problematic. So this was sort of a very novel observation that perhaps this wavelength could eliminate that retropulsion. So a number of publications have now looked at what are the differences that are unique to these two devices, and what are the important differences. So this slide here just to highlight those. And so wavelengths, although roughly very similar, actually the effects are quite a bit different, which we'll talk about in a moment. The thulium fiber laser has much more variation in terms of energy ranges that you can use, as well as the pulse frequency. And there may be some clinical advantages to that as we speak about later. The energy source, a little bit different, and again, why that's important is thulium fiber laser, it's air-cooled, so it's a much smaller box, much more portable. It's a standard power outlet. You don't have to modify your operating room as we would have to with high-power homing lasers. And I think one of the very unique things about the thulium fiber laser is that smaller laser fibers can be utilized. So to address that issue, perhaps, of the lower pole stone and not being able to reach those with our conventional homing laser fibers. There's one other unique difference between the thulium fiber laser, which is highlighted here in this slide, and that is the bottom panel, the pulse duration and the pulse profile. With the homing laser, there is quite a bit of variation from pulse to pulse. So what that means is the effect may be somewhat different. As opposed to with the thulium fiber laser, you can see that square pulse duration profile, which means that the energy is much more uniform. So in other words, each pulse gives roughly the same amount of energy. And so that may be where some of the efficiencies lie with respect to things like quicker fragmentation of the stone. Mentioned water absorption is a little bit different with these two lasers as well, and why that is important. Well, the thulium fiber laser's higher water absorption coefficient means that if we use that as a surrogate for destruction of cells, it produces a much more quicker ablation ability. So for soft tissue applications, you can actually cut the tissue much quicker. And also for lithotripsy applications, that Moses effect that many of us have heard about with the high-power chromium YAG laser, well, actually this Moses effect, of course, is relevant for all lasers. It actually may be more effective with the thulium because it really allows that second ablative destructive energy burst to be much more efficient. It will hit the stone because we have the full energy. We haven't absorbed it all in the water. So the idea that this Moses effect actually be maybe a more efficient process than with the homing YAG technologies. Pulse length is another thing that has been identified as a difference between the two wavelengths. I think, though, the question here is whether or not this makes any clinical importance. The impact may not be quite as significant, although this remains to be seen. We do know in theory, though, that there are some advantages to the ability to vary the pulse length or pulse duration. And what we have shown in numerous publications now is that with a shorter pulse length, you can ablate the stone or the tissue much quicker and a larger volume, but that comes at some cost. And so a longer pulse length actually may be more efficient. And why would that be so? Well, that may prevent degrading your laser fiber to a great degree. You may have that repulsion minimized as well. And for dusting capabilities in the stone, it does look like the longer pulse length actually is more efficient, more beneficial. So again, ability to have ability to modify the pulse duration is something that I think is quite unique and maybe to our benefit. We talked about the importance of smaller laser fibers and the ability to advance our scopes and to deflect into the lower pole. But there's another advantage to smaller fibers, and that is that it allows us to produce a much higher energy density, and that's really the key element in terms of ablating a stone. You want as much energy as possible, and hopefully as quickly as possible. And so just a simple matter of decreasing your laser fiber diameter from 200 microns, which would be the smallest homing YAG laser fiber that's on the market, say something that's 100 microns, so like for thulium fiber lasers, you're increasing the energy density by 4. So that really allows a much more quicker and ablative effect. So that's advantageous as well. Next, I'd like to talk about some of the data. clinical and preclinical data. We'll start with preclinical. A number of studies have looked at a variety of parameters. I've highlighted a couple, I think, of the key ones here. Some ones that have looked at different types of stone composition to see how the foamy mag versus the fluid and fiber laser compare. Most of them are showing that the ability to fragment stones is quicker, more efficient with the fluid and fiber laser. The rect repulsion effect that was shown in the early studies also seems to pan out, at least in these preclinical studies, where it looks like with various settings with the fluid and fiber laser, generally you can avoid or minimize the rect repulsion effect. Some concerns about this higher energy that the fluid and fiber laser can provide. Does it cause some deleterious effects, such as heating the fluid, perhaps to a dangerous level that in a clinical situation could lead to some tissue fibrosis? And certainly there does appear to be a higher degree of temperature creation using the fluid and fiber laser. Lastly, that study on the bottom line there is just looking at the effects of laser lithotripsy, what it does to the laser fiber itself. And I think we've all seen the foamy mag laser that we often will see pieces of the fiber breaking off the tip. We've been using it for a long period of time at higher energy levels. Well, there's even micrometric damage that we don't even see, which could be harmful as well. It might reduce the efficiency of the laser. And so if foamy mag is seen with the longer pulse duration with the fluid and fiber laser, that was not observed. This was one study that was just recently published, and I included this because I think what it has also shown now, something that we're seeing clinically, which maybe hadn't been assessed properly in preclinical fashion, is the different stone compositions and how does the fluid and fiber laser work for the various types of stones. And one of the observations I've had is that calcium phosphate, pure calcium phosphate stones don't seem to break as well or as efficiently. And interestingly, in this in vitro study, which was from Dr. Traxler's group, the red starred stone compositions, calcium oxide monohydrate, and carbonate apatite, pure calcium phosphate stones. When they looked at scanning electron microscopy and some infrared spectroscopy studies, it looked like those two stones actually did maintain their integrity, did not break up quite as well as some of the other stones. So there may be something inherent here in terms of how the fluid and fiber laser works in terms of breaking up some stones better than others. So I think that's a very interesting observation. I think, though, if I could summarize what the preclinical studies have shown us thus far is that the fluid and fiber laser certainly is able to dust, which may be an advantageous clinical benefit, and the fiber is able to produce much smaller pieces of stone material than any of the other lasers we've used for lithotripsy historically, including the foamy mag. There does appear to be, if you're using longer pulse duration, less burn out, less damage to the fiber. The rect repulsion does seem to be less. It's certain, depending on which settings you use. Again, we're seeing a bit of difference though in terms of how efficient certain stones fragment, particularly the harder calcium oxide monohydrate and calcium phosphate. And I think one of the things that the preclinical studies have highlighted but really have not answered, I think, conclusively is there any harmful effect to using this laser, and can there be some deleterious effects due to heating, overheating in tissues? And it's the clinical data that's going to give us some more information about that. So in terms of the clinical experience, so first of all, I think to preface this by saying that a lot of the clinical data is not really good data. It's a lot of small series, single institution, retrospective, and so we know there are limitations and biases, obviously, with those types of studies. Hard to really take much from that literature. Many of us who started using this laser were looking to that literature to give us guidance on what the proper energy settings, what the pulse frequency. Of course, many of these studies use quite variable parameters, so a little bit hard to actually assess that. I think one of the problems, too, with the current literature is that a lot of the outcomes are very different. Some just look at the optic time, is quicker to use this laser, stone-free rates, not all of them even reported on that, which obviously would be the ultimate outcome that we should be assessing. And it's been used in various types of procedures, PCL, uroscopy, system with holopaxy. So the data is a little bit muddy, shall we say. Certainly one of the key themes, though, that seems to be coming out of this early data, though, is that the dusting seems to be better. And this little video here, for those of you who have seen the helium in action, if you get it to work, I'm showing this video. This is a soft stone, which I purposely have chosen here. And you could argue, the foamy mag is going to break this up just as well, and I totally agree. I think the point of this video is that there's a couple of things. There's very small fragments that are being produced. I don't think foamy mag does that as well. So you're really seeing that so-called microdust, identifying particles. And the other thing I think to notice here is that for most of this procedure here, the laser is actually not even in contact with the stone, and it's still producing its effect. I think that's another key element here. So you can actually produce ablation of these softer stones. I think that's how the dusting technique actually works the best, is when you're not actually driving it into the stone, which usually causes the fragmentation, and then you have to treat the bigger fragments. This allows you really to treat the surface and produce that fine dusting, which I think is the goal around with this particular laser. So that's another advantage. A number of clinical studies have looked at outcomes, and again, as I mentioned, some of these are a little bit suspect in terms of their ultimate recommendations because of the quality of the studies. Some of them are very short in duration. Some of them have not really reported stone-free rates, all kinds of variations in terms of what frequencies, what energy settings to use. So I think the bottom line here is helpful, but perhaps hasn't really made the case as strongly as perhaps what we would like to see. This is, I think, a publication that has tried to put this body of evidence together in a concise way by doing a systematic review, looking at some of the better quality studies. There's about 60 of them that they were able to include in this. And, they kind of hedged their bets a little bit in the final recommendation. I mean, their thought was that the fluid fiber laser is a potential game changer, but again, did say that we need longer term studies to establish the true safety and efficacy. So not exactly a ringing endorsement. I think this paper is perhaps the best that has been published, and just recently published this year, a prospective randomized study from Scandinavia. They looked at the HOMIAG versus the fluid fiber laser. You can argue maybe the patient numbers are maybe not quite as good as we'd like to see, but a reasonable sample size. And what did they find? Well, they did see that the operative time of the fluid laser was less compared to the Homium. And more importantly, their stone-free rate was better with the fluid fiber laser at 3 months, using CT-KDB as the imaging modality. And particularly for renal stones, it was quite a significant difference. And again, probably relative to the dusting capabilities of the laser, so the pieces of the fluid were smaller, they pass quicker, more readily for the patient. So to summarize the clinical experience, poor quality, maybe not the greatest studies to hang our hat on. We really do need more multi-center studies. There's been one randomized trial, as I just described. We need more with bigger numbers, and that should really, I think, help to answer the questions we need answered. I think the optimal settings, despite the literature that's out there, still need to be better defined, and I'm just still learning myself. I've probably done about 50 or 60 cases with the fluid laser now, and I must say I've modified my settings throughout my experience with it as I learned a bit more about how to use it. I don't think one energy setting for every type of stone is correct. I think they can be modified based on stone composition, stone size, etc. My general guidance when using this laser is what we're using currently is to kind of keep the power low when you're working the ureter in particular, primarily because of that concern about maybe thermal effects. So I keep my power less than 10 watts in the ureter. In the kidney, usually less than 20. Need a little more space to work in, so perhaps less concern there. We'll usually keep it less than 20. For bladder stones, not so much of a concern there, so generally less than 50 watts. Often dealing with much larger stones, and so that works really well. The data to date with respect to complications would suggest that there's maybe no significant difference despite some of the theoretical concerns about the thermal effect, but I think this still remains to be seen, and we need a bit more longer-term evidence to that point. We certainly know from a theoretical basis, as I mentioned, that there are some potential safety issues, particularly with tissue injury, strictures of the ureter, therefore. And this was one very interesting case report that was published in the Canadian Urological Association Journal this year, where they described a renal artery pseudoaneurysm that occurred after a flexible uroscopy with a fluid fiber laser. And we weren't exactly sure why this happened. There was no frank perforation, but it could have been the energy settings that they were using. And there's more than just a thermal effect with this laser. There's probably a bit of a shockwave effect, and perhaps there was some barotrauma related to that. But again, something that is obviously very concerning, and we need to watch for.
2 minutes.
Thank you. So from a safety perspective, I think key point here: keep the energy low. get some experience with it, and I think we'll wait to see as we get some larger series about what some of the risks really are. But fluid irrigation, quite important to keep the heat down. So some of my personal observations, I think I mentioned a few of these already. I'm very interested to see the differences with the various stone compositions, and I found surprisingly cysteine, which is typically a hard stone, actually breaks up incredibly well with this laser. It does very, very well. Uric acid stones similarly as well. One of the things that we've had some issue with is carbonization. Some of the hard stones, they actually get this blackness that develops on the surface of the stone, and it doesn't really break it up very well. That's the time when you make sure that the fiber is not in touch with the stone, almost in just a millimeter off of the stone, that non-contact kind of application. That seems to work really well. I have found retropulsion still is a bit of an issue with this laser, and so making sure that your pulse energy is as low as possible seems to help reduce that risk. With the time left, I'm just going to talk briefly about the soft tissue applications. There's even less data to support this application in the literature, but it's being used for a variety of indications: BPH, urothelial tumors of the bladder and upper tract, ureteric strictures and urethral strictures, but really all small series, non-randomized. This is just one example, a study that looked at using the cold knife versus the thulium fiber for ureteric strictures. Really short fall of only 3 months, or 6 months, pardon me, but they did show that post-war residuals and heat flow rates were about the same, so it works, but for how long? Similarly, the BPH studies, lots of them, some of them good size studies, 800 patients in that first one on the list there. They're showing improvements in IPSS, quality of life, Qmax, PVRs, in par with what we would see with any of the other modalities. So it seems like it works. And durability, I'm sure. Dr. Ming Bajani from Canada has done a fair bit of work with thulium as an enucleation device, is using these settings and finds this works quite well. It seems to be quicker in his hands in terms of compared to the holum, but again, not a lot of evidence to support it in the long term. So definitely some potential role for holmium for BPH. The one study that's done some comparative work compared to holum would suggest that perhaps the enucleation times are not really that different, but maybe it's easier to learn compared to holum. And whether or not the symptom control is going to be durable remains to be seen. So I think just to conclude, I think I could say that the thulium fiber laser is an evolution, certainly what we have for laser lithotripsy. We still need much more experience in the literature. It needs to be certainly improved before we can say that it's going to supplant current other modalities of treatment. But certainly there are some features that are intriguing. The ability to treat those larger stones, maybe reduce the need for PCL in certain populations. Less retropulsion maybe means the procedure is quicker. And maybe stone clearance is better. One clinical trial is suggesting this, that was done randomized. And then maybe then a reduction in some of the disposable costs that we use now with the homing so basketing and things of that nature. If we don't need to do that, if we can dust and not have to extract, maybe that's going to help. And then finally, the smaller fibers, maybe we're able to get to those lower pole stones now more readily. Maybe we don't damage our scopes as well. So soft tissue applications, yes, there are some. And its superiority remains to be seen. So to answer my initial question, is this really the real deal, or are we dealing with a marketing ploy? I think the answer there is stay tuned. It remains to be seen. There definitely is some benefit to this device, and whether or not it will overtake the homing laser, remains to be seen. And I think this is a very telling quote from George Creel, who was one of the co-founders of Cleveland Clinic, maybe very relevant to this discussion. So if the scientific fact only lasts about 7 years, the life of a favorite treatment is half that. So who knows what the next technology coming down the pipeline will be promoting. So finally, I'd like to just close by inviting all of you to the Canadian Urological Association annual meeting, which will be held in June in 2023. Those who've ever been to Canada, it's a great opportunity. Montreal is a wonderful city, particularly in June. There's no snow. It's usually very warm and friendly, and some of you can attend the meeting. Thank you for your attention.